Thank you very much, Martin. Okay, can you all hear me? All right, so I know you've been invigorated by the photo session, but I also know that you're keen to get to Bangalore and the sites, so I will keep this to time. It's counting down, that's great, but I also want you to ask as many questions as you like, and I'm very happy to curtail my talk. I'd rather you be interested and asking questions than get to the end of my talk. All right, so this is where I work in North Queensland. This is a Cairns campus, a newly sort of minted, a bit like this environment here, Australian Institute of Tropical Health and Medicine, so I feel very at home here in Bangalore. The climate in North Queensland is extremely similar. And so I'd like to thank you for asking me to come along. I very much appreciate the invitation to be here in such an exciting city with all the ICT going on. All right, so I will begin. I'm an infectious diseases doctor. That was my original training. And then I decided, because I enjoy mathematics so much, I would do my PhD in a school of maths and statistics, and naturally enough, doing infectious diseases modelling and epidemiology. And I started a little in the work that the two Martins have discussed at this meeting, looking at hospital-acquired infections. I suspect that might be why I was invited here, but I'm not going to talk about that today. So there you go. And then I got interested in more kind of global and community and emerging infectious disease, looking into things like SARS and then Ebola and then swine flu. And finally settled in the last 7 years or so. I've been working on tuberculosis. That's what I'm going to talk about today. Predominantly, I also am very interested in the way diseases travel around the world along flight routes and so forth, but I'm mainly on tuberculosis. And I'll tell you a bit of motivation why that is. But so here's Robert Koch discovering the agent for tuberculosis. This is right at the start of the germ theory of disease. Tuberculosis is one of the key agents that really cemented the notion that germs cause disease. This is my current group working on what we call ourselves the Australian Tuberculosis Modelling Network. And what we mostly do is work with national and subnational tuberculosis programs to try and model TB and give insights into the epidemiology in that context, and also how the control programs may or may not influence the epidemiology in that context. That's the bulk of what we do, but I'll talk about a few other things today. I'm going to give a background for TB, an overview of our models, and then talk about a couple of ways that we're trying to challenge the models with data, with real data, which, you know, is something, you know, where there's a few mathematicians on our group, and that's hard to actually have to deal with data. And then after doing that, think about a little bit about what we can infer from models. And there's a number of groups who are very active in this area now doing similar things, and I'll talk a little bit about that too. All right, so you heard on Tuesday that tuberculosis is a disease that's transmitted from person to person through aerosolized droplets that hang in the air. No reservoir, no animal reservoir, just humans. And most people never go on to get active TB. They're infected, but they're not active. And some people, maybe 10 to 15%, go on to get active TB. And TB, when it's in the latent form, often isn't even visible to a chest X-ray. It's just a tiny little tubercle there. When it gets active, it can either spread through all the organs through dissemination, and in the lungs that looks like this, miliary TB, but it can also just infect other parts of the body too, a lymph node, a bone, something like that, and be non-infectious. This is much less infectious than that. This is the more mature type of TB that adults get, and tends to sort of be in one part of the upper lobes of the lungs, and sometimes gets a cavity, which makes it highly infectious. So there's a lot of heterogeneity in the way that TB is transmitted in infectiousness. So back to a bit of history. TB has been with us for ages and prehistory. It's been found in bison, 20,000 years ago, in humans, 7,000 years ago, and Rebecca here can tell you a lot more about that, exactly when it crossed over or became a human disease, but it's sort of the order of tens of thousands of years. All right, and it has been a scourge. It has been, you know, in my opinion, and I'm obviously very biased, one of the most important infectious diseases to humanity. And have a look at what Robert Koch said back when he was discovering the disease. 1/7 of all human beings die of this disease, and of the people dying in middle age, 1/3 are dying of TB. I mean, it's extraordinary. And then what happened in the developed world, right, is it's just started falling right down. And that wasn't because of antibiotics, they came in here, and it wasn't even because of testing, but it almost certainly had a lot to do with standard of living, right? So these really kind of complex social dynamic things that are really hard to model, actually. But there's a totally different story globally, right? Globally, TB is the #1 infectious disease pathogen killer in the world, and it kills more people per year than HIV and malaria combined. And we've been really slow, scientifically and politically and everything, to realise this. It's sort of quietly crept up on us, but now the things are starting to mobilise. So I know this is a long background. I just thought I'd show you figures for India, because over breakfast I was sort of told, oh, is it really a big problem? Mortality for TB per year in India is getting up towards 500,000 people. I mean, extraordinary numbers. And what happened just at the end of the last millennium is things were getting a lot worse. And they were getting a lot worse in one part of the world, which was sub-Saharan Africa, and it was because of HIV. And we heard about that yesterday in the talk about HIV, about how the life expectancy plummeted, and now it's getting better. And TB too has started to turn around in these countries, but it's more because of the action on HIV than it is because of the action on TB, okay? Because HIV causes TB, or is very strongly associated with TB, and it's starting to turn over. So action on TB. Okay, here are the biggest obstacles impeding progress: drug-resistant TB and just how hard it is to treat, and then missing cases and just how hard they are to find. They're the two biggest things, all right? So that's the background of my talk. The WHO and the UN are now mobilising and have put together, so the original Stop TB targets were just like, let's stop this epidemic from growing. Let's try and, stabilise the epidemic. Now we're getting a bit more ambitious. We're like, we really want to get to pre-elimination by 2035. But this is not a model. This is just people saying, oh, let's try and get 10% reduction a year. Let's try and get 17% reduction a year by sort of doing our best. And here's the current global trends. And that one's optimistic, right? This one is very optimistic. And this one, we really are not going to get there unless we have something new to show. Okay, so I just want to contrast this, which is the aspiration, and it's great to be ambitious. I'm not trying to criticise as such, but this is the multi-modelling exercise that I was involved with, essentially trying to do the same thing but using models for sort of realistic, where are we going to be, are we going to reach the NTB targets? And my team was one of these lines, but there were 11, I think, in the biggest group, this one, and we all kind of said, no, it's not going to happen, all right? And I'll go through the models in a sec as to why, and we also looked at scaling up various detection strategies and improving treatment strategies and all sorts of different scenarios, and the answer was essentially, it's not going to happen. Okay, we're not going to meet the NTB targets, so this is difficult. So now I'm going to talk to you about modelling. All right, so we start with a simple SIR model, which you've all heard about already in the week and probably used and come across before. It can show sort of an incidence curve. It can also provide things like what is R naught and what is the vaccination threshold for preventing disease and so on. It has some really attractive features, but of course for TB it's a little too simple because we know that TB has this long latency period. You can be infected and then decades later come out with TB, and so we popped in a latent compartment here. In fact, 2 latent compartments, and I'll explain that in a moment. All right, so this is, in my view, the bare bones, simplest possible model you can use to model tuberculosis. Is everyone happy with that model? Like, want to make any objections or any more explanations? Okay, I'll go on. Now, the other thing about tuberculosis is that it's very, very age specific. People who are under 10, certainly under 5, they're not infectious. They can get really sick and they're more likely to actually shoot over to being infected, so this rate's really high, but they don't infect anyone. And as you mature into your sort of teens, you can become infectious, all right? You get a different kind of disease. So age actually really, really matters, depending on the question, of course. Sometimes you can squish all those age groups together and just average them. But in some questions, like, does finding and treating these people in households work or doesn't it work? Age actually really matters a lot. Like, you can protect the under 4s, but they don't participate in the transmission events of they're not infectious. So, okay. All right, now, so what I want to just show you here is that because we go to national TB programs and ask them, what are your questions? What do you want to know about? What are you investigating at the moment? They'll say something like, oh, we want to look at Gene Expert, which is much more sensitive at picking up TB. And all of a sudden, our models get crazy complex, right? And too complex in some ways. And then they might say, okay, but we've also got HIV. We want to look into a particular group of people who are sort of not engaged in the healthcare service. We want to stratify by that. And next minute you got, you know, something ridiculous, right? Like that. And that probably overstates the complexity because there's a lot of redundancy across parameters and things like that, but it still gets really, really complex. And we are doing this, but it also gives us pause for thought to think about our original model and how certain or otherwise are we about the model and the sensitivities to some of the assumptions that we're making in the model. So I want to just, and this is the sorts of things we're hoping to sort of feed back to countries, but we want to be kind of sure that we're not telling them something that is not at all robust. All right, so I just want to reflect for a moment and talk about two things where we've tried to challenge models with real data to see whether the models that we've got from the literature and that we've assumed to be right are actually right. All right, so first of all, latency. We've talked about latency. This is what we used originally from the literature. We had, you know, flows. We assume that once you're in this second latency, you're very, very slow at getting active TB, but in the first latency, you sort of fairly quickly shoot off to either stabilisation or infection. Okay, so that's basically where we started from, and this was based on literature numbers that we actually got from literature, and this sort of general dogma number 1, there's a lot of TB dogmas I'm going to talk about. 10 to 15% lifetime risk of active TB following infection, and half of this risk happens in the first 5 years. That's the dogma. You know, it's not too bad, but I'm going to tell you how we sort of looked at challenging this. So the first thing we did was looked at what everyone else has done in the literature, did a literature review, and the different structures for latency in the literature. So the first one was no latency. The second one was a single latent compartment. Third was this single latent compartment, but then you can shoot across very quickly if you get infected. There's also, of course, force of infection going on here, which I haven't talked about, but but is there. You can shoot across and get infected immediately, or you can go slowly through this latent period. The fourth model is the one I've already described. The fifth model is just like the one I've already described with an extra parameter in here to allow you to shoot across really quickly. And then the sixth model is something different. It's instead of having latency in series, it's latency in parallel. But you still need 2 compartments for this sixth model, all right? And these are the number of articles. There's been a fair bit of work going on in TB. The majority of people favour model 3. We took model 4, but we weren't the only ones. David Dowdy, for example, first described it. Probably not first described it, but he described it. And then there's a few people doing model 6 and 5. All right, so we were really excited about this because we're sitting in Australia, we have hardly any TB, maybe 1,000, 1,200 cases a year. So what are we doing investigating TB? We have hardly any transmission. But here was an opportunity where Australia could help because we don't have a lot of transmission. So we can be pretty sure, like 99% sure, that people who get one infection of TB are never going to get exposed again, right? So we didn't have to worry about this confounding factor of reinfection, which you have to worry about if you were doing a similar study, say, even here in India, but certainly in sub-Saharan Africa or Papua New Guinea or some of the other sites that we work in. So we went through all of our, and the other thing is we were collecting contacts. We weren't just collecting active TB, but all those latent TB contacts, whether they converted, etc. And we sifted through those contacts to the ones that we were really sure were proper new exposures to TB. We had the epidemiological evidence that they were household members or very close contacts of active smear-positive pulmonary TB cases, and we had the evidence that they had converted their skin tests. So really clear evidence. Or if they hadn't converted, they were strongly positive at baseline and maybe born in Australia, never seen TB before, etc., something like that. So we got 613 such cases, and more than 10% developed TB over a 5-year follow-up. And we did a sort of time to event analysis on that. And further, we did have one confounding factor in our study as well, which was that people were often offered isoniazid preventive therapy. So we also did a study which is meant to stop you getting TB. So that's a problem for our analysis. So we did an imputation where we allowed that some of these people would be taken out of the denominator, if you like, because they couldn't get TB. We also allow for things like death as a competing risk and migration and so on. So here are the basic results, which I guess goes along with the dogma, 10 to 15% of people ever getting TB over a lifetime. But mind you, we've only gone for about 5 years here. If you allow for imputation, it might be 15% already by 5 years. And what was interesting, there's quite a few things that are interesting about this. We looked at it by age group, and it was very strikingly different by age group. So here we have adults that sort of just chug along and 3% over 5 years. This is a little bit more like the dogma, I think, this one here. But then children, very high risk early on, we kind of expected that. And then nothing, like 0 children after about 100 days or 150 days. And then adolescents, or the child / young adolescents, similar story, a lot early on and then nothing, 1 out here, and that was it. So really interesting. I was actually expecting this group to have hardly any TB, to have less than adults, but they had a lot more than adults. And the reason why I thought that is because this age group here, if you look at incidence, has the lowest incidence of TB. So they have the lowest incidence, yet they have quite high activation and active TB rates if they get infected. That's really, I thought that was quite interesting. Anyway, there we go. All right, so then, of course, these curves need to be converted into modelling parameters, and we're going to compare them with what we thought they were going to be, and challenge the different models. So in addition to our Australian data, Roman Raganet, who was a PhD student at the time, now postdoc, looked at some very similar studies in the Netherlands, which actually had quite similar findings, and he looked at both ours and theirs, and tried to fit these different models to the data. And what you can see is, well, model 1 doesn't have latency, so you can't really, it's not even here. Model 2 and 3 fit quite poorly, but model 4, 5 and 6 fit extremely well, and there's really nothing to distinguish them in terms of fitness, goodness of fit, sorry. I'll talk about fitness later. The model that we've been using actually can fit the data very, very well. And what we found out as well is that model 6 and model 4, when you look at them analytically as they're predictors of what IT will be, conditional on arriving in latency, what is your likely arrival time in I, you actually get the exact same solutions out. So you can't distinguish between model 4 and model 6. And anyway, further, because we had essentially, sorry, go back, in the childhood ones, oh yeah.
So in model 5, what was the S that you get? Because if S is very, very, very small, then it's also positive, right?
Yeah, precisely. So we got rid of model 5 because it was no better fit, F was small, and so we're just looking at model 4 and 6, yeah. Because obviously 4 is kind of a nested version of 5, yeah. Well, good point. Now, additionally, for the children, remember I said that there was nothing happened after about the first few months. So for the children, nu was extremely close to 0, and this nu was also extremely close to 0. So we could get rid of that flow as well. So that's what this is, without any loss of goodness of fit for children. And so there's that. All right, so going back to what we started with, what we found when we actually challenged this with data was the model itself is pretty good at picking up on the latency, but the results, the actual values are quite different. So depending on whether you're an adult, adolescent or child, this rate that we thought was happening is actually way too low and it should have been much higher, but it's compensated a bit because that rate should also be much higher. So the actual fraction leaving early is similar, but they leave a lot earlier than we thought. Instead of it being 5 years, it's, you know, it's 5 months, right? Or maybe 9 months if you're an adult. And then this rate here, this slow rate, probably should be even slower. All right, so we've refined our parameters a little bit and we've contextualized them to different age groups as well. But interestingly, 2 levels of latency is necessary to capture these. Early reactivation is higher. Late reactivation is close to 0 for those infected early in life, at least until the teenage years, because we haven't followed them for long enough. We're going to have another look at them when they become teenagers. Yeah, and so rates of activation and transition are higher, and we can't distinguish between Model 4 and Model 6. And that's really interesting because Model 4 and Model 6 are kind of very different biologically, right? Because Model 4 sort of says, you know, you get your TB and then if your immune system's on the ball, it'll kind of stabilise it. If not, you'll go straight to I. Whereas Model 6 says, well, you're either someone who's likely to be a rapid progressor or you're not. Very different biologically, but indistinguishable from the data that I've shown you. Sorry, do you allow for models to?
Someone progresses to
Oh yeah. In our fully simulated models, yes, people can go from infected back to being susceptible or back to being latent, right? Not in this though, because all we were doing was following people. We didn't care about them after that. We were following them from the point of exposure to the point of infection. So we didn't need to have that in our models, but in our fully joined up simulations we do. We allow people to go back to being other things, yeah. Okay, so where were we? Okay, so then the other dogma number 2, 2/3 of people who get TB die of TB without treatment, and it takes 3 years on average to either recover or die for the whole thing to happen. This is pretty close, actually. So what Ramon did, and this is just a work in progress, so it hasn't been published, it's just in progress, is looked at 60 cohorts of patients observed prior to the chemotherapy era, so first half of last century, and divided them into smear negative and smear positive cohorts. So they all had pulmonary TB, so their lungs were involved, but only 2/3 were smear positive. And this is why he divided them into the 2. There's a very distinct difference between smear positive mortality and smear negative, and he set up a very simple kind of competing risk model where if you have active TB, you die either of natural causes or TB, or you might recover spontaneously, in which case you then die of natural causes. All right, and just some brief results is that your mortality rate if you've got smear positive TB is 40% per year, but that competes with self-recovery rate of 25% per year, so in the end, about 2/3 of people or more die of TB. If you're smear negative, that's more like, I think it's 2.5% and 20% respectively, and about 16% death rate. So you hang around for a lot longer if you have smear negative disease. And this is interesting because smear negative disease is not, it does cause infection, so presumably it's not entirely smear negative, if you know what I mean. And the infection rate of smear negatives is thought to be about 1/6 as much as smear positives. And if they stick around for 3 times or 4 times longer, then maybe they're causing quite a lot more of disease than we thought, simply by being the missed cases, if you like. So there's a lot we still don't know, and I'd really like to keep challenging some of the models and the dogmas in TB with data. Do smear negative cases convert to smear positive? No one actually knows that. Presumably they do, but it obviously takes a lot longer for these people with low-level TB to die or become smear positive. Is there immunity or otherwise to reinfection? We don't know whether we're dealing with an SEIRS model or an SEIR model. Really, I mean, we know that people can get reinfected, but is there some partial immunity going on or not? And then let's not even talk about BCG for now, but BCG is only a partially effective vaccine. It wanes over a lifetime. It probably doesn't do anything for infectiousness of people when they do get TB. So a lot of those questions are still up for answer. But let's talk about dogma number 3. MDR arises from patients who don't take their tablets and therefore will disappear if programs just do TB well. All right, that was really the prevailing dogma up until, I don't know, maybe 5 years ago, to be generous, maybe 10 years ago, okay. And therefore MDR TB wasn't really addressed. So, right. So I'm going to look at this from a simulation and modelling point of view. All right, and in case I don't get through all of this, I'm going to give you the punchline now, which is that so the thing is that people thought, okay, drug-resistant TB strains, they lose fitness, they lose too much fitness, they're never going to take over. All right, but then someone came along and said, actually, there's some compensatory mutations, they might be getting fitter. So we don't quite know where we're at with fitness. And there's so many different strains, right? It's going to be really hard to tell. But anyway, it might take decades or more for strain replacement to occur. So just because it hasn't taken over yet doesn't mean it's not heading that way. MDR can dominate even if its transmissibility is modestly reduced. All right, I'm going to show you that. And controlling drug-susceptible TB only works if MDR TB is so unfit that its reproduction ratio, its basic reproduction ratio is less than 1, right? Okay. All right, so here we are. We're back to the sort of bare bones model. Then, of course, we have to add in another strain. So I'm just going to totally replicate this, but put it in red for the MDR TB strain. Everyone happy with that? And of course, we have to allow some superinfection of drug-susceptible TB. People can get drug-resistant TB, and drug-resistant TB people can get drug-susceptible TB. We model superinfection on top of latent infection as going back to the early latent class. Yep.
There is top-line infection here, that's not possible?
There isn't in this model. Okay, it's an interesting thing that we need to look into, but I believe people do pick up multiple infections of TB, but when they reactivate, they tend to reactivate only a single one of those. Okay. All right, so we've just allowed time to do the damage there. Yep. Oh, no. This is through transmission. This is through contact with these guys. Okay. So these people. These red arrows are influence arrows. People don't, hang on, let me just have a look. No, they're not. These arrows are real arrows. They happen because these guys, so this arrow, for example, here occurs because one of these interacts with one of these and pushes that one across to here. All right? And this arrow happens because one of these guys interacts with one of these guys and pushes it across to here. Okay, I've taken all the maths out just because, you don't want to read it, but it sometimes can be confusing, I'm sorry. But this is something that you might want to know about. So it's this one here. So if people are infected and they are getting drugs, and this is drug-susceptible TB, and they fail or default or are lost, then they have a risk of getting de novo drug resistant. So this is the same person becoming drug resistant. So there's two ways to get drug resistant TB. You can either be susceptible or any of these guys and be in contact with a drug resistant case. Okay, so that's this flow. Or you can start off drug susceptible and become drug resistant. Yeah. So that kind of all is. At the moment, what we do is some people do, they say, okay, if people self-cure, we stick them back into here. right, from infection. But I think what you're talking about there is sort of all captured by a very big simplification around here. So people either, they're susceptible, they get exposed, and they either return to susceptible or move on to latent, or go to I there. It's kind of, I know this is a bit of a simplification because it's very complex, and there's no way there's only two latency kind of phases. So I've heard people talk about 5 or 6. So I take your point, the model doesn't capture everything, but basically...
Be a backwards arrow as well.
There is definitely a backwards arrow, I've simplified it, okay? So, but it usually happens here. Okay, so if you self-cure, yeah, there's that arrow. I've just taken it out for the moment. Okay, and 1/3 of people also self-cure. All right, the other thing that you need to know is that if you're only doing smear testing, you're not going to be able to tell the difference between drug susceptible and drug resistant TB until people fail their first line therapy, right? If you're doing Gene Expert, which is specifically designed to capture MDR TB, you're going to be much better at finding people, treating them, all right? So that's a big issue too. All right, I want to just quickly go through some work that a PhD student of mine is doing on this model, looking at, it's basically the same model, but he's collapsed the latency compartments because he's only looking at long-term equilibrium solutions. So in fact, the latency compartments matter when you're talking about time to an event, and they also matter a lot if you're talking about doing something about the latent state. But here, where you're just looking at equilibrium solutions, they don't matter so much. So same model structure. There's that same asymmetry where drug susceptible can become MDR, but not vice versa. And I just want to quickly show you through his equilibrium states. There you go, some equations. All right, so the first one's the disease-free equilibrium, also known as the trivial solution, and where there is no disease, and you can show that that is stable as long as both the drug susceptible and the drug resistant strain have an R0 less than 1. No surprises there. All right. Then the second one, which is the next most interesting, is if MDR dominates. So that's if MDR TB has an R0 that's higher than the drug susceptible strain and greater than 1. And what it does is it's got the same susceptible pool drawing from, and it squeezes out drug susceptible TB. Now here, if we allowed for co-infection, we would get different dynamics, but we're not doing that. And then the third one, which is if the drug susceptible strain dominates, you get co-infection, and that's stable anytime that R0 for the drug susceptible strain is the highest, and it's higher than 1. All right? So what is going on there is that R0, so that you get predominantly drug susceptible TB is being produced, but it will always, because of this arrow, create some MDR TB. And depending on how close the R0s are of those two strains, you might even get more MDR TB than drug susceptible TB. So this is that result here. So what Abdul's done here is taken a very fit, to start with, a very fit drug susceptible strain, and then reduced its sort of transmission fitness. And right here, this dotted line is equal fitness, but this dotted line is where the prevalences and the incidence, I think it is, cross over. So all of this in between, all of the difference here is because of that, what we call amplification pathway, that asymmetry where people can go from being drug susceptible to drug resistant, but not the other way around. Okay? Back to, so that was Abdul's work. I'm going to go back to the slightly more complex model and show you something on some simulation work. I'm really only going to show you a couple of slides on this because it's just so hard to do heat maps. All right, so what I want to just draw your attention to, this is the relative detection rate of MDR. You know how I told you it's really hard to detect? And this is the relative transmission fitness of MDR. So if we just take the equal 1-1 there, what we find is that MDR TB dominates. In the dark blue, that means drug susceptible TB dominates and MDR doesn't stand a chance. But as soon as we cross this threshold, it's really MDR that's dominating. All right? So if we just left things go and the fitness was equal and the detection rates were equal, we'd be in big trouble. And that's because MDR has a considerable advantage being harder to treat, more likely to have failures, and therefore you spend more of your time infectious, all else being equal, right? If you have a fitness cost, that can actually, we can sort of hope that MDR doesn't in fact dominate, as long as the fitness cost is of the order of about 30%, which might be, this area might be where we're sitting at the moment. If we if our detection rate of MDR-TB, which is probably about half at the moment, even though it doesn't make a huge difference, if we can improve it just a bit, you can see we're right in that area where we can make a big difference for whether MDR-TB dominates or doesn't dominate at all. All right, and that's really all I'm going to say in terms of heat maps and things. All right, so remember I said you can either get amplification, going from a drug-susceptible strain to a drug-resistant strain all in the same person, or transmission. So this looks at the relative amounts of each. So obviously when you first introduce MDR, it's got to be all through amplification if there was none to start with. But you then transition over to predominantly being from transmission, and then at that point you don't need any more amplification. It's really just the spark, right? You just need the spark to get the whole thing going. And as long as if the R0 of MDR is bigger than the R0 of drug susceptible, it'll take off all on its own. So that's what we've got to work out, whether we're in that sort of situation right now. Okay, so conclusions from this work: even with a fitness cost, MDR could dominate. Early MDR emergence, more people require MDR through amplification, but don't let that lull you into a false sense of security. And then MDR may drive out drug-susceptible TB, but the reverse doesn't happen. Okay, whew. Right. So this is my last part of the talk. And again, happy for interruptions. This is sort of more the kind of bread and butter of what we do, which is this context-specific simulations, national TB program support. So we want to try and give get modelling to give insights into what may happen in a single country or a single province, specific to their kind of epidemiology, their health system, and their control activities. And we want, yeah, so I've said that. Okay, so what we do is we sit down with a group of people. We usually travel to the country a few times and learn about their health systems, learn about their epidemiology, and then we kind of, this is my messy writing, I'm afraid, sort of do this kind of brainstorming where we try and work out what they want to do in their health system that would change things, and of course spend quite a lot of time trying to interpret those changes into a model. And some things we have to say, look, we just can't model that. There's not enough evidence for us to model that, or it'll be something like, you know, we want to put an advertising campaign on telly to tell people to go and get tested for TB or something. And sometimes there is evidence to support that, and sometimes there's not, all right? So we do that, and then we show them this toy model, which I think I've got a little bit of time just going to show you, because it just sits on the internet and anyone can play with it. See if I've got it here. Yeah, where we sort of, you can toggle the population size up to a point. If it gets too big, it can't cope. This is just all kind of taking place on the server. We're a little bit slow at the moment, but they can play around with the different levers, and it really is great for control program people, because they're not technical experts. They don't want to see a whole bunch of ordinary differential equations and so forth, but they can really relate to the levers of, you know, what changes, you know, TB epidemiology in the long run. I can't show you that in animation at the moment. It's not, the internet's not letting me. Okay, back to this. All right. And then, you know, we've refined the model over the years. We have lots and lots of different strata and so forth, depending on what strain it is. And indeed, this will go in a sec, I think, that is one part of a much bigger model, which has things like optimization and health economics to it as well. And we read through a lot of data from the public domain, as well as from people's own program spreadsheets and so on, in order to do the modelling. And I just want to give you one example, and it's not important that you take all of this in, but this is Fiji, tuberculosis in Fiji, and they came up with 6 different things that they wanted us to look at. One was this gene expert business that I told you about. One was support for patients in treatment, doing prevention at the latent TB level, but at the moment they were only willing to think about changing from under 5s to under 15s as the people that they will treat. See, under 5s are the most vulnerable, but like I said, they're the least infectious, active case finding and so on. And so what we can do is, having interpreted all of those into model parameters as realistically as possible, we can then look at what that might do. So we've got the baseline of what, they're already doing quite a bit, and so we could say, well, baseline carried forward, we get some impression on incidence and prevalence and mortality and notifications. And then here's the alternative, all the different scenarios. So might just take, and you're probably looking at this and thinking, oh, that's really not great, right? It's not great. Even this, the purple line represents doing all of the 6 scenarios combined, and this is what we do to incidence. This is where we want to be. And this is what we do to mortality, and this is what we want to do. And this little blue line here is interesting because this is what we found when we shut off all transmission, right? So in other words, their scenarios are really good at shutting off all transmission. They get there, right, within a decade or so. But they still don't reach the Millennium Development Goals, right? So what we're finding again and again with all of our countries is that there's this vast pool of latent TB as transmission declines, and it's going to keep driving TB, and we're not going to get to the Millennium Development Goals. All right, so maybe we need to redefine the goals, or maybe we need to address latent TB. Okay, so common findings in all our work. NTB goals are not achievable with existing tools, and latent TB will obstruct countries from realising their NTB goals. Another finding, which I haven't mentioned up until now, is that mortality, as reported by TB programs, is around 1/3 to 1/2 of that predicted by models. And I believe these are the missing cases. So I think there's not just missing cases, missing deaths from TB. And what you'll see here is this is mortality as per the National TB program. And a lot of the things that we do actually increases the mortality as per the National TB program. That means because we find more cases, we have more cases around, some of them die on our watch under treatment, but in fact what it does is actually reduces overall mortality, but that's somewhere up here, right? We don't even put that in our models, it's too scary, okay? It's like 3 times as much. Okay, I'll leave it there. This is a picture of my Townsville campus, and I work in this office over here, and I'd invite you all to come join me there sometime. Thank you. Got 1 minute left.